لله ملك السماوات والأرض يخلق ما يشاء يهب لمن يشاء إناثا ويهب لمن يشاء الذكور أو يزوجهم ذكرانا وإناثا ويجعل من يشاء عقيما إنه عليم قدير.
بسم الله والحمد لله. اللهم صل وسلم على نبينا Muhammad. Amma ba'd. Assalamu alaikum wa rahmatullah, and hello to everyone. Thank you all for joining us this evening, or is it afternoon where you are. It's the first webinar of Al-Azim Masjid Alumni Association, FUNAB. And on behalf of the members of the association, I welcome you all. This webinar is a response to the several reports of unpleasant happenings in our society, from issues of security, rape, ill health, unemployment, suicide, etc. But today we are beginning with pregnancy management, starting with pregnancy management. And that's because of the increasing report of pregnancy-related challenges. And of course, there are cases of pregnancy loss, labor complication, and several life-threatening issues that has to do with pregnancy and delivery. So to tackle this, we felt it's important to first of all educate one another, both the male and female, the husband and the wife, educate one another about pregnancy, perhaps by understanding what pregnancy is all about, by knowing what to do and what not to do in this situation, and knowing how to assist a pregnant woman and how the woman herself can manage or prevent some of the risks associated with pregnancy and delivery. I believe this will go a long way in reducing these sad issues. So with henceforth be giving you information about important issues in the society, either via a webinar or some other means. So today we have the pleasure of hosting Dr. Habiba. Dr. Habiba is a resident doctor in obstetrics and gynecology at Yambul and Nakhal Hospital in Medina Munawwara, the Medina province of Saudi Arabia. Dr. Habiba received her training in Nigeria and abroad, and she is a member of several national and international medical societies. Presently, she is serving as a member of the COVID-19 response team in Medina, and of course, she's extremely busy. Thank you for giving us this time. So apart from clinical engagement, Dr. Habiba is interested in research, and her interests include maternal recognition of pregnancy, embryo endometrial communication, delivery, and all that has to do with pregnancy management and delivery. Today, she'll be talking on successful pregnancy management with little or no complication. So Dr. Habiba, you have the floor now.
Thank you, sir. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for the nice introduction. My name is Habiba Adesoya. Thanks for having me. We'll be discussing successful pregnancy management with little or no complications. Briefly about me, as you said, I studied in Nigeria. Afterwards, I came to Saudi Arabia. And I've been in Obst and Gynae in Yambu and Nakhal Hospital since then. So to have a successful pregnancy, we can't really rule out complications, but we want to try as much as possible to minimize the complications such that if at all we are going to have any complications, it will be something very minimal. So that's why we have this topic as having little or no complications.
Okay.
To begin with, as Muslims, we already know that, and we know and believe in Qadar. We believe that everything is with Allah. At the same time, we need to try our best to ensure that we stay healthy. We take precautions. We seek help when the need arises. And of course, we have to entrust, our life is being entrusted to us by Allah. We need to take care of this. And an hadith is being quoted here, and go through it. Someone asked the Rasul sallallahu alaihi wasallam that, should I tie my camel and trust in Allah? Or should I leave the camel and just trust in Allah? The Rasul sallallahu alaihi wasallam said, tie your camel and trust in Allah. So, meaning we have to give our best, our all, in trying to stay healthy. Then, afterwards, we can now say, we leave everything to Allah. So, to begin with, as pregnancy, what do we mean by pregnancy? Pregnancy occurs when the sperm cell from the male fertilizes the ovum from the. So I said pregnancy occurs when the sperm cell from the male fertilizes the female ovum. This forms the zygote. This forms the zygote, which now implants into the female uterus. Uterus simply means the womb in layman term. From this picture, this is the uterus. This is the uterus. I think you can follow with my cursor. And the tube. And this is the ovary. That's containing the egg from the female that forms baby. So after copulation, meaning sexual intercourse, the sperm cell comes inside and fertilizes the egg from the female. This now moves back into the uterus to implant. So from this definition, we have three things that is needed for pregnancy to occur: the sperm cell, the ovum, and the uterus. So out of these three things, two belong to the female. Hence, our major our discussion today has to do with the female. So we have, in order to have a successful, to manage the pregnancy successfully, we'll be discussing, I'm going to divide it into three. First part is prenatal, meaning before pregnancy. Pregnancy starts even before you get before you actually have the baby growing inside. So we need to prepare for this baby. The natal, which is the actual pregnancy state, and postnatal means after pregnancy. So the prenatal stage, what are those things that can cause adverse effects in pregnancy? So the first thing is the age of the woman. Presence of any underlying medical conditions, inadequate planning, and for those that have been married and had kids before, nursing a previous child. So the first one, which is the age of the woman. Extremes of ages, meaning the young females as well as the older females. Young females meaning age less than 18. And the older females, age above 35. These two age groups can experience a very challenging pregnancy. And for the young female, the reason behind this is because their body is not fully matured. And most of the time, we might have our sisters around, and we notice that their period is irregular. And why is this so? This is because the organs that are producing the hormones that regulate their menstrual cycle is yet to fully mature. Females release hormones which causes the ovum, that is the egg, produced by the ovary, from the diagram I showed earlier, to mature. So, how is this ovum being released? From this picture, this diagram depicts the menstrual cycle. The menstrual cycle essentially starts from the first day the woman starts bleeding to a day before another bleeding starts. So the ovum is released by the mid of the cycle. For a woman that has a 28-day cycle, so the mid cycle will be around the 14th day. Usually menses is, the normal cycle is between 21 to 35. If your period falls between 21 days and 35 days, that is normal. And bleeding should be normal bleeding should be between 2 to 7 days. If you bleed for 3 days, 4 days, 5 days, or 7 days, it's normal. Anything beyond 7 days is prolonged. So, if the ovum, is released by the mid-cycle, which is the 14th day, once it's been released, and peradventure there is copulation around this time, that means it can be fertilized. And if fertilization takes place, pregnancy has already begun. So, but this woman is still expecting her period. She doesn't know she's pregnant, and she still has 14 more days, because I said fertilization occurs at the mid-cycle. The last 14 days of the cycle is constant. For someone that has a 22-day cycle or a 25-day cycle, the last 14 days is constant for everyone. So if your period is 25 days, the last 14 days is constant. That means your ovulation will be on the 11th day. 25 minus 14 is 11. So that means your ovulation will be on the 11th day. And you menstruated for 5 days earlier. So that means day 1 is this. You menstruated for 5 days. You have just 6 days before the 11th day. 6 free days. So by the 11th day, the egg is released. And there is fertilization. Your body just needs to wait, the uterus just needs to wait for 14 more days. That's 2 weeks. For someone that there's no copulation, maybe a single lady, egg is released on the 14th day here, ovulation. The uterus waits till the 2 weeks, the 14th, another 14 days. Once there is no fertilization of the ovum, the endometrium, that is the inner layer of, this is the inner layer of the uterus, it's being shed as the menses. I hope we understand. We can write down our questions and ask after the discussion. So, okay, that is for this. This stage is called the follicular stage. Follicular means another egg is growing. This egg is growing, it gets to this, ovulation takes place, the egg is released, it waits in the luteal phase. If nothing, this big layer, the endometrium, is being sloughed off. If there is fertilization, this egg, fertilized by the sperm, just comes inside the endometrium to implant and start growing. Now for the older females, why is there a risk associated with them? This egg that we are talking about, the egg has been formed since the woman has, since conception, since when this woman is in her mother's womb. That is when this ovary has been formed with the eggs. All what happened later afterwards is just maturation. The woman gets to the teen age, maybe by 9 years, or maybe by 10 years, or 11 years, or 13 years, she starts menstruating. This ovum or the egg is not just being produced, it has been there since she was in her mother's womb. So the egg that has been there when she was in the womb, till now she's 35 years, the egg is already getting old. The hormones that is regulating the cycle is now becoming irregular. After 35, some females start having regular cycle. The cycle doesn't come. Rather than having a 28-day cycle, they start having 35-day cycle, 40-day cycle, sometimes 2 months before another menses comes. So at this age, I said there is increased chances of having births, giving birth to babies with congenital anomaly. The eggs are old and the hormones are not as they used to be. So that's why females are always advised to get married early. Now, apart from the age, what else? Previous or underlying medical conditions. Medical conditions such as heart disease. For people that have heart disease, they are prone to several other risks. Probably they may be on medications. If so, these medications should be reviewed by a doctor before getting pregnant. Women that have diabetes. For women that have diabetes predisposes them to having babies with congenital anomalies. That means anomalies that start from the womb. So such women probably are already on some tablets to control this diabetes. These tablets that they take, for example, metformin, also called glucophage, these tablets should be changed. They should not be used while pregnant. The woman should change their medications to injection, insulin injection. So that is why the preparation for pregnancy is before conception. So they should change their medication to injections. For women that have epilepsy, most of the drugs taken by epileptic patients causes abnormalities with the baby. So they should change to a safer drug. Thyroid problems, women that have this problem should repeat the test, have their medications reviewed, because if the thyroid hormones is high or probably low, they are prone to having miscarriages. So I'll explain this. They should have their medications reviewed. And for diabetes, they should change their tablets to injection. And these women with diabetes, they should start taking folic acid. We have something called neural tube defect. This has to do with the brain and the spinal cord. Diabetic patients have high chances of having baby with neural tube defect. So taking folic acid helps to prevent this defect in their baby. Adequate planning. For newly married couples, they should seek advice or go for counseling before getting pregnant. This should include running some baseline tests, viral screening, blood grouping, genotype, hepatitis, etc. For genotype, we know if a woman is AS and the husband is AS, there are chances that they will have a sickle cell baby. The baby will have sickle cell disease. For blood grouping, women that has blood group negative, that the resource is negative. The reason why they need to have this test done and be prepared is because, one, the husband also need to be checked. If the husband is also negative, then there is no risk for them, because most likely if both are negative, their children will also be negative. But if the woman is negative and the husband is positive, then after delivery, they need to immediately check the baby's genotype. Because if the baby is positive after delivery, then the woman needs to take an injection. This injection is called RhoGAM. And if not taken, there's nothing, no adverse effect on the baby delivered. But subsequent pregnancies are at risk. The woman is prone to having miscarriages, because since the woman is negative, meaning that she doesn't have this resource, but the baby has the resource. And that means that the antigens, this resource antigen, the woman will already develop antibodies. By the time she gets pregnant again, the body of the mother sees the baby as a foreign body and fights this baby. So she will keep having miscarriages afterwards. For hepatitis also, she needs preparation, because there is a particular injection the baby is supposed to have if the mother is hepatitis positive. After delivery, the baby should be given the injection before they start immunization. And the woman needs to start treatment. So other diseases like HIV, if a woman is HIV positive, she should start antiretroviral drugs and ensure that the viral load, the amount of the virus is low, and CD4 count, which actually measures our immune system. Let me put it like that. So the CD4 count should be high with low viral load. She should ensure this occurs before getting pregnant to reduce the chances of cross-infection to the baby. If I'm too fast, the admin can please let me know. So other things that can cause adverse effects in pregnancy is nursing nursing or breastfeeding a child. Pregnancy on its own is stress. And for a woman to be nursing a child, I feel it's too much, because the baby inside, as we say it medically, is an obligatory parasite. Whether a woman eats or not, the baby in the womb will tap its own nutrients. It will take its own glucose. But this woman is breastfeeding. So the child will also take the milk. What will be left for the woman? Such a woman will be malnourished. She will be weak. And over time, the baby might not get enough nutrition. So there are chances of having miscarriages. And even if the baby survives till 10, there are chances that the baby might be small for age. And having a small for age baby poses its own risk as well. So what are the things that should be done, or that can be done, to ensure that a woman has a normal pregnancy, to ensure normal pregnancy? So first, having a balanced diet. Married females preparing to get pregnant or are in marriage should have balanced diets rich with fruits and vegetables. Avoid self-prescription. The fact that your neighbor has an ailment and took a particular medication does not mean that same medication is what you need. Avoid herbs. We have some prophetic medicine, but I believe that it's not all that can be taken by pregnant women. And also, apart from that, their quantity that can be taken will differ from someone that is pregnant and other that is non-pregnant. So the best thing is to avoid herbs, because from the explanation earlier, you might be pregnant while you are still unsure, while you don't even know you are pregnant. Also, avoid rigorous exercise. Have adequate rest, adequate water intake, and spacing between deliveries. So this enables your body to go back to the pre-pregnancy state, and all the hormones of pregnancy goes back to normal or near normal. Now the natal stage, the actual state of being pregnant. Pregnancy can be divided into 3 parts: the first, the second, and the third trimester. Each comprises of 3 months. The first 3 months of pregnancy is the first trimester. During this stage, all the organs and of the body has been laid down, are being formed. Organs such as the heart, the lungs, the kidneys, the intestine, they are all being formed. That is why the first trimester is called the critical period, which I will explain again shortly. So from this picture, this is the baby in the womb. This is the fetus, the baby. Day 1 from the cycle I showed earlier, fertilization takes place. Day 1 for the baby is the 14th day, the mid-cycle, when fertilization takes place. And I said once the fertilization takes place in the tube, it goes back. Let me go back to the picture. Yes. This is the egg. Once it's fertilized, it takes 6 days to go to migrate to the uterus and implant. So on this mid-cycle, once the egg is released and luckily it gets fertilized, it takes 6 days to burrow into the endometrium, to the inner layer of the uterus. And from this picture, I said there's still 14 days before the end of the cycle. So the woman is still expecting her menses to come during this time, after 2 weeks. after the 14th day. Where is it again? Okay, so by day 22, that is the the early part of the 4th week, the heart has begun to beat. This baby starts making its own blood. So essentially, by the end of the 3rd week, the backbone, the spinal column is being formed, the nervous system is being formed, the liver, the kidney, the intestines. So if the woman wasn't careful enough, she might have been doing some things that will hinder or that will cause complications for this baby. By the 4th week, let's say by the 5th week, the eyes, the legs, the hands begin to develop. By the end of the 6th week, that is 1.5 months, the brain waves are detectable. By the 7th week, the eyelids, the toes, nose, everything is being formed. By the 10th week, you can see the baby is already big. Starts moving, the baby starts breathing, the lungs are functioning already. So the first trimester, the first 13 weeks is a critical stage in which any insult can have a lifelong effect on the baby. So to this, to recap, okay, this is the picture again. The egg is released on the 14th day for someone that has a 28-day cycle. Even if it's not 28 days, even if it's 25 days. So if it's 25-day cycle, that means on the 11th day, the egg is released. But it still has to wait this compulsory 2 weeks here. So the woman is already fertilized. The woman is still expecting her period after 14 days. Unfortunately, this may be absent for some, so they will know, okay, they missed their period. But some, they will only notice slight spotting. They menstruate usually for 5 days. But this time around, it only came for 2 days and very little. So they may think that probably I need blood tonic. Maybe because I'm weak. Maybe because I'm not eating well. They just give themselves an excuse. Or maybe because, I don't know, it just came like that. So they think all is well. And they have to wait another 4 weeks. This is 2 weeks gone already. By another 4 weeks, at this time, nothing is coming. Nothing came up. So it's already 6 weeks. But they might be thinking, okay, maybe this month is delayed. Let me give this thing a few more days. So by that few more days, that means the pregnancy is already 6 to 8 weeks, going to 7 weeks or 6 to 8 weeks, thereabout. So that is why women should be cautious. The preparation starts before the egg is, the preparation for pregnancy should have started before the fertilization at all. So congenital malformations in babies during the first trimester leads to miscarriages. Most often times, there will miscarriage. Although some of these babies can survive, and this will lead to having babies with defects. So what do we do? What are the precautions to take in the first trimester? Taking folic acid, it helps a lot to prevent some congenital anomalies. Getting the right prescription for ailments. For example, someone with fever, body pain, vomiting. Rather than go to the hospital, she went to the chemist. Or sometimes might just tell the husband, please, when you are coming from work, can you get me some drugs from the chemist? I have fever, I have body pains. So the most likely thing to be the diagnosis in Nigeria by the chemist will be malaria and typhoid. The chemist will definitely most times prescribe Coartem or Lonart and Ciprotab. Ciprotab is contraindicated, contains ciprofloxacin, is contraindicated in pregnancy and lactation, should not be taken by someone that is pregnant or someone that is breastfeeding. And from the previous explanation, I said this woman is not even aware that she is pregnant, she's still expecting her period. So just, I would just like to say this. How do we know that this drug is not safe in pregnancy? Especially for antibiotics, how you can just give a guess is any drug, any tablet any antibiotic tablet or capsule that there is no syrup available for it. For example, this Ciprotab, you can't see a Ciprotab syrup. So just know that this Ciprotab is not safe for someone that is pregnant or breastfeeding. Augmentin, there's Augmentin syrup, so it is safe in pregnancy and lactation. Amoxil or Ampiclos, there's syrup available for those two antibiotics, so it is safe for pregnancy and lactation. Erythromycin, there's tablets, there's syrup, so it is safe. What other antibiotics? Tetracycline is not safe. It causes anomaly. So for someone that has diarrhea, stooling, don't go and take tetracycline. They usually call it Talazole. Don't buy Talazole. There's no syrup for Talazole. Taking Talazole will cause browning of your child's teeth. It affects the teeth. Taking chloramphenicol can affect your baby's bones. So avoid those drugs while pregnant. Even if you are not sure, you think you are not pregnant, so far you are not using any contraceptive, stay away from those drugs. So another thing that can occur in the first trimester is ectopic pregnancy. This is a medical emergency. I have to say that first. And what does this mean? What does it mean by, what do we mean by ectopic pregnancy? Ectopic pregnancy simply means pregnancy outside uterus. I will explain further. So what are the causes of this? For primigravida, meaning the first pregnancy, for no known cause, it's been discovered that ectopic occurs more in women in primigravidas. 2, previous ectopic. I think this can sound wicked. For someone that has ectopic, they have high chances of having ectopic again, which is sad. Family history, previous PID. PID means pelvic inflammatory disease. What does this mean? To diagnose PID, it means that there's fever, there's abdominal pain, there's vaginal discharge. It's usually called toilet disease. It is not toilet disease. It is pelvic inflammatory disease. But people know it as toilet disease. So if you have fever, abdominal pain, and vaginal discharge, seek medical help. The reason why I'm explaining this is because someone might have had PID when she was 15 years old, and she got married around 22 years or 25 years. If the PID was not properly treated, it causes what is called adhesions, some abnormality inside the uterus. So by the time she gets married and the egg is fertilized, when the egg is moving from the tube into the uterus to implant, it gets stuck because of the adhesions that were caused by that PID a long time ago, over 10 years ago. So this puts her at risk of having ectopic. So your child is having, I don't know if you have older males here, if the child is having these symptoms, fever, abdominal pain, vaginal discharge, take the child to the hospital and get the child properly treated to prevent this PID, which can predispose the lady to having ectopic pregnancy later in life. Another cause of this ectopic is use of intrauterine device, IUCDs. IUCD is a device being put in the uterus to prevent pregnancy. It can cause ectopic. Something is already in the uterus to prevent pregnancy. If the baby really wants to stay, we'll find somewhere else. Since there's no space in the uterus, it can go to the tube and implant there. So from this picture, this is the uterus, this is the tube. These are the different sites where the baby can decide to implant. It can decide to implant in the ovary itself, or here, here, here. But the most common part is here, the isthmus, which is the narrowest part of the tube. As it's coming, this place is narrow. It can get stopped here. And from this picture, this is the uterus. These are the tubes. This is the ovary. These are the tubes here. So this here, the red arrow, is showing the baby that's already implanted in this tube. So from my previous explanation, the woman is usually not aware, because ectopic pregnancy, the problem starts when the baby gets to around 6 to 8 weeks, which I've explained before. She's not aware that she's pregnant. Well, she's just expecting her menses to come, or she can say it's late. It's I was expecting it last week, but it's still not coming. So she suddenly presents with severe abdominal pain and bleeding. Sometimes it may not be bleeding, but the abdominal pain is severe. If the person presents in the hospital, definitely the doctor for every female abdominal pain has to do with pregnancy until proven otherwise. So a good doctor will definitely ask for about her menstrual, when was her last menstrual, her last period, and will run some pregnancy tests. But if she just has severe abdominal pain and she goes to a chemist, they will prescribe something else. So for ectopic, the presentation includes amenorrhea, abdominal pain with bleeding, plus or minus bleeding. The most common location is the tube, this thin part of the tube. So with this, we can see it's already bulging, the tube is bulging. It can rupture, and once it ruptures, the person starts bleeding. This bleeding can be very severe, leading to shock and death. So it's, I said it's a medical emergency. This woman, if taken to the hospital, needs immediate surgery, and will be needing about 4 pints of blood. So it is not something to keep at home, because most times such patient with ectopic pregnancy gets to the hospital in shock. They will have been going all around and round and round, and the pain is not subsiding. So they usually come in shock and immediately taken to the theater with about 4 to 6 pints of blood. The next thing we'll be discussing is the second and third trimester. I'll be discussing this together. For this stage, all the organs are already being formed in the first trimester. Now the baby is just growing. So the second and third trimester, the baby just keeps growing, and there are changes to the uterus in preparation for delivery. Second trimester is another 3 months. That is from the third to the 6th month. Then the third trimester is from the 6th month till delivery. Okay. So what are the complications that can occur during this period? The first one that I'll be discussing is hypertension. Someone can be hypertensive before being pregnant, but our topic here is on hypertension in pregnancy, or we can call it pregnancy-induced hypertension. It's different from someone that has hypertension before getting pregnant. She will probably have been on some medications. But for someone that registered, that's why a woman should get prepared. You are already prepared for this pregnancy. Once you are sure you are pregnant, you should get registered in a hospital. And definitely in the hospital, they will check your vital signs, your blood pressure. So you got registered maybe around the 9th week, the first trimester. Your blood pressure was 120/80. Pregnancy-induced hypertension starts after 20 weeks of gestation, and this can last till 6 weeks post-delivery. So if by 7th month, or let's say 30 weeks, the woman comes in with blood pressure of like 145/90. Okay, definition for hypertension is blood pressure. Pregnancy-induced hypertension is having a systolic blood. I'm sorry. I was about using some medical jargon. So having a blood pressure of 140/90. When you have a blood pressure of 140/90, then you can diagnose this person or this woman as having a pregnancy-induced hypertension. Usually in the second trimester, the baby is growing bigger, so the need for the baby's needs will increase. So the mother will have increased blood flow, but this blood should flow at a reduced pressure. If your blood pressure is 120/80 before you got pregnant, by the second trimester, your blood pressure should drop slightly to something around 110/70. It should drop because the baby needs free flow of blood, not blood under high tension. So having a high blood pressure can pose a lot of risk. One, it can disrupt the blood supply to the baby. The baby will not get enough because the blood is just flowing very fast. So the baby is not getting enough blood, not getting enough nutrients, not getting enough oxygen. That's one. It can damage the organs of the mother because this same blood is flowing, is being distributed around the body for the mother as well. So it can destroy the kidney, organs such as the kidney. It can affect the liver, every part of the woman's body. There's another condition called preeclampsia, which is due to this high blood pressure. If the blood is flowing under high tension, as I said, it can destroy the organs such as the kidney. The kidney should not, there should not be something called protein in the urine. Once the blood gets to the kidney should filter the blood, remove the waste from the blood. Any protein that was filtered should be reabsorbed back to the body. But if there's problem with the kidney due to this high blood pressure, it destroys the kidney. So the kidney will not be able to reabsorb this protein. The woman starts leaking protein in the urine. So for a woman that is pregnant, you check the blood pressure, it is high, 140/90. The next thing to check is the urine. Is there protein in the urine or not? So depending on the amount of protein in the urine, this will determine the severity of the preeclampsia. So apart from damaging the kidneys, I said it can damage the liver, it can also damage the brain, causing reduced oxygen supply to the mother's brain. And this can lead to convulsion. When a pregnant woman convulses, this is called eclampsia. It is a very fatal condition. So for a woman that is pregnant and has high blood pressure, they may not have any symptoms. Some may not have any symptom. Some can complain of headache, insomnia. Insomnia means inability to sleep. And some, it can be pedal swelling, that is their legs are swollen. Their face can be puffy, swollen face. And that is that. So hypertension in pregnancy is something that is very, very dangerous. Women should be monitored, should be placed on some medications in order to reduce this blood pressure. Okay, I don't know if we still have time. For someone, okay, I once saw a patient. She was brought to the hospital at, I think around, sorry, I need to check. Okay, she was brought to the hospital around the 6th month, let's say around 25 weeks thereabout. And you know, in Nigerian hospital, before someone gets to the government hospital, to Island maternity, the person will have gone to maybe like 3 or 4 different hospitals. So this woman was brought in around 25 weeks, a young lady, that was her first pregnancy. She has already convulsed maybe 2 or 3 times before getting to the hospital. She got to the emergency room and had convulsion, I think once or twice. The baby is 25 weeks and the woman has already convulsed 3 times. what are we supposed to do? Are we going to leave this woman to continue this convulsion and die? No. The next thing is to bring out this baby. You have to pass a tablet to our private parts to induce abortion for this woman to bring out the baby. So this was what was done. I was a young doctor doing my internship, and we did this in order to save the woman's life. After that, few months later, I think I was in another posting, surgery posting or medical posting, I'm not sure. I was in the canteen trying to get something to eat. And the woman just said, Alaja. I just gave her a rama. The next thing she was like, you don't know me? I said, I'm sorry. I can't remember the face. Then she said, hey, Kole, you, are you not the one that killed my baby that time? I was so shocked because her voice was so loud. I was like, I'm sorry. I was trying to bring her to one corner, and what happened? I'm sorry. I don't know what happened. It's like, Naila maternity that time. You are the one that, I was like, I'm so sorry, because I was so shocked that how can she accuse me? Although I can't really blame her because she doesn't know. Someone that's convulsing, she was not here. She was unconscious. So all she knew was that she woke up and there was no baby, and this is the person, they said this was the person that brought out the baby. So if eclampsia occurs early, once eclampsia occurs, there's nothing to say. We don't have any, the baby is out of consideration, let me put it like that. All what the doctors are after is the mother, trying to save the mother. Whether the baby comes out alive or not is not the issue. What we are concerned about is for the mother to be safe. Once the mother is safe, she can get pregnant again. So no matter how many weeks, you don't keep such baby, bring out the baby. If the baby is big enough, maybe probably the baby is like 34 weeks or 36 weeks, then fine, the baby can survive. But 25 weeks, the baby cannot survive. So we just have to save the mother. So to show how serious this condition is. The next thing I'll be discussing is diabetes. Increase in blood sugar. Women can be diabetic before getting pregnant. But this diabetes I'm talking about here is gestational diabetes. Diabetes that occur in pregnancy. This person does not have diabetes before getting pregnant. Suddenly, she went to the clinic and they checked her blood sugar and it was high. So this high blood sugar can damage the baby's organ. It can, the baby is getting too much glucose. Diabetes means high blood sugar. The baby is getting too much sugar. So such a baby will be big. And during delivery, it poses a risk to the mother. The mother can be advised to have cesarean if the baby is very big. And if the mother insists to have normal birth delivery, it can cause tear and all sorts. And after delivery, there can be brain damage to this baby. Let me explain further. This baby is accustomed to having high blood sugar. Suddenly, the baby is being delivered. He or she came to this world. And you are feeding the baby with one tiny bottle or just the small, immediately after delivery, the milk from the mother is still little. So the mother is feeding this baby with this little milk, the baby that is already used to having high sugar. So such a child will go into hypoglycemia. The blood sugar of this child will become low. This baby loses consciousness. And the mother doesn't know what is happening. Probably she delivered in one small clinic close to her house or all these maternity homes or traditional birth attendants. They don't know that this woman is diabetic, or they don't know what hypoglycemia. They don't know what to do. Before they take this baby to the hospital for treatment, hypoglycemia causes brain damage. Once the blood sugar gets below 40, for baby below 50. Once it gets below 50 for more than a considerable amount of time, it damages the brain. Even if they give the baby so much sugar afterwards, baby comes around, the brain damage is already there. So the next thing we'll be discussing, I talked about high blood sugar, pregnancy, gestational diabetes, and pregnancy-induced hypertension. The third thing is antepartum hemorrhage. Antepartum means during pregnancy. Bleeding during pregnancy. It's of two major types, abruptio placenta and placenta previa. For abruptio placenta, abruptio, meaning that this placenta suddenly detaches from its point of attachment to the uterus. The bleeding in abruptio can be mild, can be severe. It can be revealed or concealed or even both. So from this, where's my cursor? Okay. From this picture, it's all the placenta that is already detached. But sometimes it might just be just a little part of the placenta that is detached and little blood trickles out. So for this now, it is concealed. Nothing is coming out, so the woman doesn't know, but she will be having severe abdominal pain. So that's one thing about abruptio. There's severe, sudden severe abdominal pain. For this, part of the blood, part of the blood is coming out. You can see everything is detached. For such baby, once the baby loses blood supply, there's loss of blood supply and oxygen, the baby is already dead. What you are after is how to keep the woman alive so that she doesn't bleed too much. This woman needs to be transfused with blood. So it's a very serious condition. So what are the causes for this abruptio? What can cause the placenta to detach? One, hypertension. As I said, blood flowing under high pressure. The blood is coming in under high pressure. It can detach this. Sometimes a woman's blood pressure is 200 over 100 or 210 over 100. It can cause abruptio. The placenta can detach. Or fall. A woman is on a Okada, motorbike. She fell down. That sudden force at which she hits her buttock on the ground can cause sudden detachment of the uterus. Sometimes it can be caused by drug overdose or some very concentrated herbs. See a woman that was brought close to time. I think that day was her EDD, or the next day should be her expected date of delivery. But she was brought in the night with abruptio placenta. Obviously, the baby died. The woman had, I'm not sure, maybe 4 pints of blood or 6 pints of blood thereabout. So it can be very disheartening. Another cause of antepartum hemorrhage is placenta previa, meaning low-lying placenta. This is normal placenta up. This placenta is called marginal. And see it's closed. This is os. Os means the opening of the uterus, called cervix, vital os. So this is close to the entrance where the baby, the passage for the baby. This is partial placenta previa. Just a little part of the placenta is covering the os. And this is complete previa. So for this, you can see attempt vaginal delivery. For this, it's not possible because the place is covered, and this totally impossible. So why is this placenta previa dangerous? The lower part of the placenta is thin compared to the muscular part, upper part. And towards the end, I said there are changes to the uterus in the 3rd trimester. This lower part is supposed to be absorbed into the upper part, such that the uterus will become more round. So this part should be absorbed, it should go in, and this place becomes very thin. The muscles here should move up. This place will become very thin. So just mere walking can trigger bleeding because the placenta is in this thin part. When the woman walks, a part of it can detach and she starts seeing blood. Sometimes it can be intercourse that can cause shearing of part of this placenta, causing bleeding in the woman. So for every bleeding, that means the baby is receiving less blood and oxygen. And the woman can keep bleeding every now and then for placenta previa because this lower part is thin. It cannot really anchor, cannot really hold the placenta in place. So every now and then the woman can bleed So if this bleeding doesn't stop, the woman keeps losing blood, she can go into shock, and this can be fatal. So what are the other complications? Presentation of the baby. Close to 10, towards the end of the third trimester, the baby's hair should be down, which is called cephalic. The buttocks should be up. That is the normal presentation for vaginal birth delivery. Sometimes the buttocks can be the parts in the lower uterine segment and the head up. This is called breech. Or the baby can be in transverse position. These two positions are not safe for delivery. This is the safest. The head pushes forward and comes out. Then it's easy just to pull the baby and the baby comes out. But if it is breech, the buttocks comes out, and can you guess what can happen to the head? It can get stuck. So if the head gets stuck, this can cause suffocation or strangulation of the baby. The baby is, you can feel all the parts of the baby is out. The head, the legs, the hands are dangling, and the head is stuck inside. You know, the sight is not something good. So the best mode of delivery for this is, even although vaginal birth can be assisted vaginal birth, not just normal delivery. Assisted vaginal birth delivery can be tried for breech, but it's not safe. For you to carry pregnancy for 9 months and just slightest mistake, it's not good. But for this transverse, there's no other discussion other than to have cesarean section. Other complications include uterine fibroid. Presence of a huge fibroid can cause severe pain during pregnancy. Depending on the location, it can hinder the growth. It's filled, the uterine cavity is filled. Where will the baby stay? Even if the egg is being fertilized, once it gets into the uterus, there's nowhere to implant. The thing keeps coming out. So such a woman will not be able to get pregnant. And for this, you can see, this baby, it can strive to get to 10, or some lead to abortion. And another thing that could complicate, the baby can be made, for this kind of baby, the delivery is cesarean. How will this baby come out? This fibroid is too huge. How will the baby come out? It's already pushing the baby. This baby will be small. The baby can't grow well. The fibroid is taking almost all the blood, all the nutrients that baby needs. It's taking everything to grow. And you know, during pregnancy, more blood is coming to the uterus. So rather than for the baby to be enjoying the blood, this thing is taking a large portion of the blood and the nutrients and getting bigger. For all this type, definitely conception is difficult. So after delivery, there can be severe bleeding. Assuming this baby is being delivered by cesarean section, normally once the baby is delivered, the uterus should contract. But with this huge mass, how will it contract? So such a woman is prone to having severe bleeding. The baby is having multiple pregnancies on its own. If the first twin, usually we're talking about twins now, 2 babies, can have more than 2. But for twins, if the first baby is cephalic, meaning the head is down, it's safe to have normal vaginal birth. 3 and 4, like that, the best thing is just to have cesarean. But for 2, you can still say you want to deliver per vagina. But before you can attempt vaginal birth delivery, you have to do an ultrasound and be sure of the presentation of the baby. If the first baby is cephalic, that means the head down, then vaginal birth can be is safe. But if the baby is breech, like for example this, the body, the legs are out. How will this baby be delivered? This is locked. We call it locked tray. Assuming this woman this woman is in at a bad, there's no access to ultrasound scan. The woman came in labor. The buttocks is out, the legs are out, but the head is not forthcoming. The next thing for them to usually do is to pull on the baby. They keep pulling, and this can cause what? Suffocation. Which is supposed to supply the baby with blood and oxygen. This cord is being squeezed here. This is already cord collapse. Cord is out. So the chances that the cord will get cold, there will be the supply of oxygen to the baby is already disrupted here. The baby it's being pulled. This baby becomes flabby, pale, blue. After some time, they eventually release the woman and tell the woman to go to the government hospital. This woman ran away from cesarean. She was probably told that she was going to have cesarean. She doesn't want cesarean. She has delivered two or three babies per vagina before. She doesn't want cesarean. What will happen? She will eventually have that cesarean for a dead baby, because this baby is usually dead by the time they get to the hospital. If she doesn't have cesarean, the next thing to do, if she still insists she doesn't want cesarean, the next thing to do is to decapitate this baby. They need to cut this place, this head. Cut this one, pull the one out, push the head back, this head back inside. Deliver this baby, and afterwards they can deliver this head. So you have to sacrifice one baby for love to. That is if you still want vaginal birth delivery. But the best thing is to go to cesarean. And if she does cesarean, definitely this baby is still dead. So why go through the stress? Why not have cesarean in the first place? Sorry. So how do we prevent all these complications? Regular follow-up. Once you know you are pregnant, register in a standard hospital where you can have your care, a government hospital, in case you may need blood. Lagos State, for example, once you register, you donate blood, you have everything in place. So you go for your antenatal care, you follow up. During this antenatal care visit, they check your blood pressure. The nurses check your blood pressure. They keep monitoring this. So the reason why they are doing this is to know if you are having pregnancy-induced hypertension or not. They check your weight. A woman is supposed to get 6 to 8 kg during pregnancy. But this woman is about 36 weeks gone, and she only has maybe like 4 kg. That baby is small. Or they also check your fever, your temperature for fever. If you have fever, they run some other tests to be sure, is it malaria? Is it infection? So that's the reason why they check all that. Like full blood counts, know the amount of blood, your blood group. A woman that is anemic, you need to boost her blood. Normally after delivery, at least a small amount of blood will still be lost. So you need to boost your blood before then. Your blood sugar, to rule out diabetes. Your urine, this is to rule out preeclampsia, protein in urine. That's what we check for. And also to check for any infection. Having infection while pregnant is more dangerous. Pregnant women have low immunity. If there is infection, it goes to the kidney. And you don't want anything to destroy the kidney. Affectation of the kidney. So you don't want any infection to destroy the kidney. The woman needs the kidney to filter the waste. The woman's waste, the baby, and her own waste. So you don't want anything to affect her kidneys. Also, during your routine antenatal care, the presentation, the amount of liquor, the fluid, that means the water, the location of the placenta, Also to be able to detect any abnormality in the baby. Sound scan. Also, they do viral screening, HIV, hepatitis, VDRL is for syphilis. Your routine drugs, essentially the iron tablets, the calcium, and some multivitamins. But you have to be careful. These multivitamins, take precautions. Especially those that have high content or high amount of vitamin A. Vitamin A is teratogenic. Teratogenesis, cancer, can cause problem. Let me just put it like that. Consumption of high vitamin A is not, it's teratogenic. So, pregnant women, rather than taking so much tablet vitamins, your iron tablet is enough. And if you are eating well, egg, milk, you might not need calcium. And even if you have to take calcium, 1 tablet per day of calcium is enough. And your iron tablet once a day is enough. Eat balanced diet with fruits and vegetables. So, medical care, emotional support, talk to your doctor, express yourself, say what you want, ask questions. Some women, when they go to, I have some people ask me questions. I wonder what you say to your doctor when you go to your doctor. You came back from the clinic, you did not ask all those questions. You are now asking me questions. Why can't you ask the doctor questions? You are being prescribed some medications. Why can't you ask what those medications are for? Your doctor checked. Why can't you ask, how is my baby? Ask questions rather than just taking everything in and going home. And once you are asked what happened, you can't really give any explanation of what transpired at the hospital. So, other ways to prevent complications is mild exercise. I'm not saying you should exercise at 20 weeks or 25 weeks. No. Towards the end, by 36 weeks, women can start mild exercise. This is to ease the pelvic joint especially. Mild walking, walk around, not just sitting down all day long. Pregnancy is tiring. You just feel tired. You are not really doing anything, but you are tired. So you need rest, but at the same time you need some mild exercise to ease your joints. Your eating habits. It's not advisable to take large quantity of food at a time. Small, frequent meals. Because the gravid uterus, that is the pregnant uterus, is being pushed aside, pushed to one side by the stomach is being pushed to one side by the uterus, by the womb. So it's small now. You need to eat small amount of food. Eating large quantity of food can cause discomfort and provoke vomiting. And this can lead to aspiration. It can go to the windpipe. And so many other complications from there. Your sleeping position, medically, it's advisable to sleep on the left lateral side. Islamically, it's the right. We know we cannot sleep on your tummy. It's not allowed, but for a pregnant woman, it's not, you can't really do that. You can't sleep on your back. The reason behind this is that the big vessel, the aorta, that carries blood from the heart to other parts of the body is in the midline on your backbone inside. If you lie on your back, the heavy uterus will press it down. The baby will not get enough oxygen. If you lie on your right side, it's said that the big vein that carries blood back to the heart, the inferior vena cava, is on the right. So this is also being compressed. So enough blood, the heart is not having enough return to it. So the woman feels suffocated. It's as if she's choking. So it might be difficult to stay on one side continuously. So you can be turning. Most women that have been pregnant, they know they feel more comfortable sitting or well propped up, maybe like 45 degrees, so that the tummy, the abdomen is down, the uterus is down. Then they can feel comfortable. Yeah, they can breathe properly when they sleep propped up. Now the next thing, at the end of the third trimester, is the delivery. So in order to reduce, from our topic we said little or no complications. In order to reduce or to avoid complications in total during delivery, couples should discuss their options with their doctor. For example, someone that has breech delivery, the safest mode is cesarean. But some women, because they've had previous normal births, they want another vaginal birth, forgetting that each pregnancy has its own peculiarity. This pregnancy is different from the other. Women that have been pregnant, they can testify to that. The fact that one pregnancy is different from the other. The way you feel during your first pregnancy might be totally different from the way you feel by the time you have your fourth pregnancy. So cultural traditions, they are insignificant. The most important thing is the safety of the mother and the child. Those are the two things that should guide your decision, not the money. For example, a woman was told that she should have cesarean. She refused. She went to a traditional birth attendant. Definitely she will spend like maybe 25 or 30,000 there. Eventually, the woman needs to go back to the government hospital. On getting there, the emergency case, all the that, the woman died, the baby died. They will be transferred to the morgue. How much are you going to spend to collect the bodies from the morgue? How much are you going to spend to do the janaza, to bury this woman and the baby? And what about the emotional trauma? Probably this woman has like 3 kids at home. How are you going? I'm talking to the fathers now. How are you going to take care of the kids? And for the woman that you think, I'm not sure if everybody is Yoruba. If you're beg or what have you? Or I've had deliveries, so there's no money. How am I going to get this money? Even in government hospital, you cannot spend more than 150,000 or 100,000. Please go and find a way to borrow this money. All your relatives, let them borrow you money. Have a safe delivery. You will recover this money. You will pay them back. Rather than losing your life, who is going to take care of your kids? Who? You don't know what will happen. So take the best or the safest route. So what are the complications at the time of labor? The first one is the non-progress. A woman is having adequate contraction, but suddenly the cervix, that is the entrance of the womb, stops dilating. It should open. But we don't know. That's why we said little or no. She has prepared. She registered in a government hospital. She did everything possible. She went for antenatal care. She did all the tests. She did everything. She took her medications. Now labor has begun and she was having normal contraction. But unfortunately, the cervix just stops. Maybe, probably she's now 6, the nurse said she's 6 cm dilated. And she keeps having this pain. So for every contraction, there's momentary reduction of blood and oxygen supply to the baby. So if labor is prolonged, the baby gets tired. There is initial irregular heartbeat. And, okay, someone is asking, for every contraction means the uterus is squeezing, trying to force the baby out. So for every contraction, there's reduction in oxygen supply to the baby. And this continues for so long. Probably they say the woman has been in labor since yesterday night. And this is 6 p.m. The baby is still here to come. So, and the woman has been having this pain. This is not pain for diarrhea. This is severe. This is labor pain. It's severe pain. over time, the woman will get exhausted, and this can lead to death. The second thing is meconium. Meconium is the stool being passed by the baby. Meconium liquor, meaning the liquor that is the water has been polluted now with this stool. So usually, the baby drinks this liquor, this water. The meconium should be passed out once the baby is delivered. It might be same day. It can even be immediately once the baby is coming out, passes it directly. It can be a few hours later. So, but in this case, the stool is being passed while the baby was inside. So during labor, by the time the nurse or the doctor breaks the water, other than for the water to be clear, it's dark green with particles. So once you notice that if the baby is in a hospital setting, the baby should be closely monitored, because these particles, baby can aspirate it, and which can lead to respiratory distress. It's blocking the lung, the pipe for the baby, so it can cause respiratory distress and death. Baby should not go through stressful labor or prolonged labor. Another thing, another complication that can occur during labor is bleeding. We have 4 T's of bleeding. 4 T's, that is 4 causes. Well, they all start with T. The first T is tone. Tone, that is uterine atony. The uterus has lost its tone. It has lost its ability to contract. The baby is out. We've delivered the baby and the placenta. The uterus, the womb should shrink, go back to its shape. So, if the baby is out and the womb remains that bag, that big sack that encloses the baby, that is not good enough. That means all the holes, all the blood vessels that is supplying the placenta, those passages, that place is still open. The woman will keep bleeding. But once the baby is out, Allah has made it such a way that the uterus shrinks. Once it shrinks, this closes up all these vessels that are supplying the placenta before. So, but if there is atony, that is, the uterus is not able to shrink, it can be, there are different causes of atony. It can be due to the fibroid that we discussed earlier, or some other things. I won't go into that. So, the uterus is not able to shrink. It causes severe blood loss through those vascular beds where that's supplying the placenta. So, for such a woman, if not in a good setting, she can keep bleeding, and this can be fatal. The other thing is tissue. This tissue is the placenta. Placenta should be delivered completely. Once the placenta is being delivered, the midwife should check, is it complete? Is everything there? So if it's even just a small part of the placenta is remaining inside, the woman will keep bleeding, because that place, the uterus will assume that the whole placenta or the baby is still there, and the blood will keep entering that place, and the woman will keep bleeding. So this placenta tissue must be expelled. Those are the things. The woman is bleeding, you check, is the uterus contracting? It is contracting. What is still happening? Is there tissue inside? Is the placenta complete? So those are the things the doctor should check for. The third thing is thrombin. This is a part of blood substance present in blood that is responsible for clotting. So if there is bleeding, excess bleeding, it uses up this thrombin, leading to DIC, disseminated intravascular coagulopathy. Medical jargon, I'm sorry about that. So it is fatal. This substance in blood should help the blood to clot. Now, the woman delivers somewhere, probably the placenta, the tissue was inside, or probably something happened, or maybe she was using some tablets, aspirin, or some anticoagulant before delivery. She didn't stop on time. So this thrombin, this thing is not being formed, and the blood refused to clot. So bleeding continues. Such a woman should be transfused with the clotting factors, usually fresh frozen plasma or a fresh blood. It cannot be done in a traditional birth attendant home, or even a small place. They don't have facility for blood transfusion. This woman needs to get to the government hospital, a big hospital. The fourth T is tear or trauma. Tear or trauma can be uterine rupture. Someone that is in labor in a nearby clinic, the baby is not coming. For example, what I said about mom progress, the thing is the baby refuses to come. They don't know what the cause. Sometimes it might be the cord around the neck. If there is cord around the neck of the baby, you will see the head of the baby. You will be seeing the head. But the cord is pulling the neck of the baby back. You keep telling the woman to push. She's pushing, but the head is not coming. What do? They push, they press the tummy to push the baby out. This can cause rupture. The uterus can rupture. And if this happens, the woman will keep it. First, immediately when this happens, the baby is not getting any oxygen, so the baby dies immediately. By the time they bring the woman to the hospital, it's an emergency. The CS or probably or whatever she doesn't like or she rejects or rebukes, they ask to be taken to the theater to deliver a dead baby. And this woman can take up to 8 pints of blood and still die. That's just truth.
Dr. Abiba, we have 10 minutes more.
Oh, I'm sorry.
So have the questions.
Okay, all right. I'll try to be fast now. I'm almost done though. So we can also have cervical tear, entrance of if the cervix is not fully dilated and the woman keeps pushing before she was told to push. You know, sometimes they will tell the woman, don't push yet, but she doesn't listen and she pushes and the cervix tears. It can cause severe bleeding. So those are the complications at the time of labor. The next is postnatal. I've talked about prenatal before pregnancy, the natal, the pregnancy state, and now after delivery, the postnatal complications. So for the postnatal complications, they can be bleeding. Apart from the bleeding immediately after delivery, the woman, she's fine. Everybody is rejoicing. But unfortunately, the blood didn't stop. She thought the blood had stopped. But somehow, she's noticed that she's using as much pad. She's not supposed to be using so much sanitary towel again, but still bleeding. So this can be due to probably some slip ligature or some other complications or infections thereabout. There can be infection. Infection can cause complications. This infection, the woman can start having fever, the blood pressure can reduce, she can go into shock, and this can be fatal. So this woman delivered, she came home, she was okay. What happened? Nobody knew. She was feeling weak and she was running temperature, she was having fever and became dizzy, and all of a sudden she slumps. The hypertension, I said before that hypertension pregnancy starts by 20 weeks, after 20 weeks, till 6 weeks. This woman has delivered. They gave her medications from the hospital because she knew she was hypertensive. But after delivery, due to the crowd, the akiko and all sorts, she forgot she didn't use her medication and the blood pressure rose again. So this woman can start convulsing despite the fact that she has delivered. She can have eclampsia because it's still not 6 weeks post-delivery yet. Just last week she delivered. Another one is diabetes. It can still, because it still can still be present in 6 weeks post-delivery. Fall. This woman is not eating. She's weak. She's breastfeeding. Everywhere is crowded. She's stressed. She's not resting. And probably she's bleeding a little. All of a sudden she slumps. Depending on where she is on the injury, she can have fracture or she can hit her head on something which can cause stroke. So, in summary, being of desirable age before pregnancy, being pregnant before 18 years, 15 years getting pregnant, poses a lot of risk. Being pregnant above 40 years and above like that has its own risk. Treatment of all health conditions before getting pregnant. Weaning previous child, make sure you are fine, you are better, your baby is fine. Let the baby enjoy the breast milk. 2 years, breastfeed, or even if it's 1.5 years. You yourself should get to recover fully before starting another stressful journey. Avoid self-prescription. Antenatal checkup, your vitals, routine tests, use of medications like folic acid in first trimester, taking iron tablets to boost your blood, having a planned delivery, discuss with your doctor on the best options. And from my explanation, I think we will be able to recognize some adverse conditions. Once we notice some things happening, take appropriate action. Your wife has been in labor. They say she's 6 cm since 2 o'clock. This is 6 o'clock. 4 hours later, she's still 6 cm. And you decide to leave this woman there. I think this is not right. And the woman herself, you heard the nurse said you are 6 cm, 2 o'clock. This is 6 p.m. and you are still 6 centimeter dilated. That is not progressing. You shouldn't leave your baby to be going through this stress. Please take the next step. If you are in a private hospital, go to the government hospital and take the next decision. Bring the baby out. Continuous monitoring and non-neglect. Please, husbands should not neglect their wives. Don't leave the care of your wife to your in-law or your mother. Ask her, has she eating? How is she feeling? Any fever? You touch, check, is she running temperature? Ask, has this blood stopped? The blood coming out, has it stopped? No? Let's ask about how she is feeling. So if you notice anything abnormal, don't scold her saying she's a weakling, don't care any. That's what you say it. And don't say, okay, maybe by tomorrow is a kickoff. Maybe after tomorrow, we'll go to the hospital, or just let me go to the chemist to get you something. This is not appropriate action. At least after this discussion, you should be able to take a better decision. And also for the women, you should be able to make the right decision as regards your health. All for the best care in order for you to be safe and for you to be able to take care of your kids. Thank you. May Allah grant all pregnant women safe and easy delivery. Ameen. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. That has been Dr. Habiba from Medina. Thank you most graciously for this interesting and excellent presentation. It's very comprehensive. We are overwhelmed with questions today, and I hope
yes.
you have the time to respond to this question.
Inshallah.
So I will read the question to you, and
okay.
Then, okay. Very quickly, some of the audience have requested for your contact. I don't know, so they want to know if we can share your contact for some question or something. So that's that. So in total, we have more than close to 30 or more than 30 questions. I don't know how we're going to do that.
Okay. Okay. Some questions might be similar. So.
Okay. Perhaps those that we are not able to answer, perhaps you can respond in writing. I will share it by email too.
Okay, no problem.
Later, inshallah. So the first question here, the person requested if you could respond in Yoruba.
Okay.
That's quite funny. So it says that what are those symptoms that when a woman sees should immediately proceed to the hospital? Okay. It has to do with pregnancy. So
okay, can I quickly answer that? Okay, let me quickly answer that. In Yoruba, àwọn nǹkan tí èèyàn máa rí tó máa mọ̀ pé hospital ó yá báyìí. One, ẹ̀jẹ̀ tóbìnrin bá ń rẹ́jẹ̀. You are not obìnrin ò yẹ kó rẹ́jẹ̀. Oyún ti dé kò rí nǹkan oṣù ẹ̀ mọ́. Oyún ti dúró. So kò yẹ kó rẹ́jẹ̀ mọ́. Obìnrin tí ó lóyún tó ti ṣe test tó mọ̀ pé òun lóyún. Tí ó bá rẹ́jẹ̀, kò ń ṣe nǹkan tó dáa kó máa lọ sí hospital straight. That is one thing. Obìnrin tí inú bẹ̀rẹ̀ sí ń dùn tó ń lọ́nú mọ́lẹ̀. So once tell about the notice eléyìí kó máa lọ hospital kó mọ nǹkan tó fa inú rírun bọ̀ inú yẹn ń gan inú dùn gan ó bẹ̀rẹ̀ sí rẹ́jẹ̀ kó máa lọ hospital. Mo ti ṣàlàyé tẹ́lẹ̀ pé obìnrin tí tó rí pé orí ẹ̀fọ́rí orí yẹn kàn fọ́ ń lo paracetamol but still náà kò lọ́lẹ̀ gbogbo ojú ẹ̀ wú ẹsẹ̀ ẹ̀ wú gbogbo àwọn nǹkan bẹ́ẹ̀ yẹn kó lọ sí hospital. Òyì ń kọ́ oúnjẹ ọbọ̀ òyì ń kọ́ still kó máa lọ sí hospital àbí ó ń bì kò lè jẹun. So àwọn nǹkan báyìí kóbìnrin máa lọ sí hospital tí ó bá jẹ́ kó lóyún. Okay, I think
thank you
that
most kindly for that. Thank you most graciously for that. So the other questions we have, someone asked about induced labor. That is it safe? Induced labor?
Well, induced labor is safe in a hospital setting because the first complication of induction is failed induction. No, they are inducing the pregnancy, but the first complication is in failed induction. So if a delivery is going to be induced, should be in a good setting where they can have cesarean because it can fail. So once it fails, the woman should have cesarean, but it's something that can be done. But only induced labor can only be done for someone that's never had cesarean or any surgery on the uterus. You cannot induce labor for someone that has had previous cesarean or has had previous fibroid removal. You cannot induce because there has been a cut there. If you induce such a labor, the uterus can tear.
Okay, thank you very much for that. I hope our audience are listening. So the third question here, that is sex selection possible? I think these are the very brief question you can answer. Is sex selection possible?
Well, it's not allowed. It's possible, but it's not allowed. Both in Nigeria,
from the Islamic perspective, or
I'm not a sheikh. I'm not a scholar, so I'm not talking from Islamic perspective. I'm talking about medical. No, it's not allowed in Nigeria, and I'm sure it's not allowed in UK.
Okay.
It can only be done in UK if there are some congenital anomaly that's associated with that sex. For example, we have some anomaly that is associated with males or females. So if the baby is carrying, they have this gene, the mother has this gene, and the father has this gene, and they are married, there are chances that if they have some X, I don't want to go to medical terms. So if they are prone to having this kind of baby, that's like a female baby that will have this particular anomaly, then once they get pregnant, they check for the sex of the baby, and if it's a female, before the baby grows big, like from 15 weeks, they do tap the water and check. If the baby is a female, they induce abortion for this baby. But it is not allowed on just because I want so sex.
Okay, thank you very much.
Okay, I want to say something about that.
Okay, you can quickly say that while I say the other question.
Okay, another way that is a rough estimate or a rough idea of how to have a male child. What they say is that if an egg or the female, if there's intercourse on the day of ovulation, the egg is fresh. The egg only lasts before it spoils. Let me just put it like that. It only lasts about 36 hours once it's released. So if immediately the egg is being released and there is fertilization, there is high chances that this baby is going to be a male. So if your ovulation is today and you do not meet with your husband today, you meet with your husband the following night, it's probably going to be a female. That is the rough. Okay. Okay.
Thank you very much, Dr. Habiba. So the next question says, what will a pregnant woman with thinning fibroid do?
With what?
Thinning fibroid. I think that should be typo.
Painful?
Thingy.
Chingy. I don't know.
Fibroid. Or let's say, what will a pregnant woman with fibroid do?
Okay, a pregnant woman with fibroid will be given pain relievers because it's usually painful. It causes severe pain during pregnancy. So depending on the location, it has to do with the location. So depending on the location of the fibroid, since you're already pregnant, there's little or nothing they can do. The baby is there. You just have to wait. All they need to do is to be giving you pain reliever to ease your pain. Take your iron medication to boost your blood because it can cause bleeding. That's all they can do. And by the time you are delivering, depending on the location, they can say cesarean. But the best thing, once you are prepared, the fibroid is big, remove this fibroid before you get pregnant. That's just the best thing. To prevent all this stress, try to do the surgery, remove the fibroid, and have a safe pregnancy, easy pregnancy. But once you are pregnant already, they can't do anything about the fibroid when you are pregnant. So you just keep taking pain reliever to ease the pain and take blood medications to boost your blood and prepare for delivery.
Oh, may Allah make it easy for all our women. And the next question says, please ma, I did a scan at 22 weeks and the baby is still at breech position. Hope it will turn to the normal position before the close of the third trimester.
Inshallah. Inshallah, it should turn. At that early stage, there is enough space. There's enough space for the baby. There's enough water. So the baby is just swimming. The fact that you checked now, the baby is breech. By the time you check that same day in the night, it can be edged down or can be trunk, can be. So the baby is just turning. It can assume different position in one day. But by the time it gets to the end of the third trimester, 34 weeks and above, you should have assumed a particular position. So inshallah, it should turn.
Okay. You can also have access to the question if you open the chat, but based on...
Okay, I'm checking. I'm trying to check, but...
Okay. Perhaps you would give some priority over others, but if you want to make it first come, first serve, then we can go with this. So the next question says, rigorous exercise affects pregnancy in the first trimester. What if in the case of where copulation keeps going on between the couples? Can this affect the pregnancy? Oh, that's an exercise.
Okay, usually it should not affect the baby, except if that copulation is so vigorous, then it can cause abortion. But if it is the easy one or this, I don't know, non-vigorous one, it shouldn't affect the baby.
Okay, I think the man should take care of that.
Yes.
The next question is, I heard it's advisable for pregnant women to sleep on our left side. Please, what can you say about this and why?
Okay, I think I've explained the left side.
Yes. Because
the right side, I said there is the cover, the vein, the big vein that takes blood from the lower part of the body to the heart. If you sleep on your right side, which is in Islamic way, it compresses on this. The blood is not getting back to the heart. You feel like you are choking. So that's why it said that you should sleep on the left. Nothing is on the left, so you sleep on the left. Even the left, you can't maintain that left throughout 8 hours sleep in the night. You keep changing. So you sleep on the right few minutes, you change to the right, to the left. Keep changing till daybreak.
Okay, thank you very much. The question is asking, please, can a concealed abruptio placenta be corrected? And could you please explain, expatiate more on the symptoms?
Okay, concealed abruptio. It can only, this concealed, I said it can be mild bleeding or severe. If it's just a little bleeding, it's checked that you did, the person had the ultrasound scan done, and it's just a little bleeding. What they do is bed rest. They give bed rest. They can give what is called the Dufastone, it's a tablet, or there is also injection form or suppository form. To relax the womb, the woman will be transfused, will be given blood if her blood is low, and it will just allow this bleeding to subside. So they keep monitoring this woman to be sure this bleeding is not increasing. So she should be on complete bed rest. The only thing that will make you stand up from that bed is if you want to pass urine or stool in the toilet. You go to the toilet, you come back to your bed. That's all.
Yeah. That brings us to another question. The question I want to know that what if the cervix open? This is like, it's a real situation. The cervix open, say in the second trimester. So, and I think it has happened from the question, it has happened to me twice. So what should I do?
Okay, if the cervix opens in the second trimester, usually depending on the age, you said it has happened twice. So the doctor will ask you at what age did it happen the first time, and at what age was the baby when it happened the second time. There's something called cervical incompetence, for the cervix to just open all of a sudden by itself before getting to term. So that means the entrance of this cervix is not strong enough. So if it's not it's not strong, let me put it like that. So it's just, what is supposed to be done is that in the first trimester, by the 10th week thereabout, they are supposed to tie the cervix. That's what they do. But usually they don't do it until it causes problem, the third abortion. But after the third one, that's when they start doing sacrilege. It's called sacrilege. They'll tie once the woman gets pregnant, by the 10th week or 11th week, she's admitted in the hospital, they tie the cervix such that it will not be open. So, by the time she gets to like 36 weeks, towards the time for delivery, she will go to the hospital, they cut the suture that they used to tie it, so that she can fall into labor at any time. That's what's supposed to be.
Okay, thank you very much for that, doctor. I think this is a very important question, just like others. Said I'm 18 weeks and I've been having abdominal cramp constantly. I've had treated UTI not long ago at all, but treating it again, other than UTI, could there be any other reason I'm having such pains?
Okay, there can be, I said PID, it can be infection. So if you're having abdominal pain, are you also having discharge? Apart from, there are several things. It can be UTI. You know, in the abdomen we have the urine, we have the uterus, so it can be PID. The problem can also be from the intestine. Are you having inflammatory bowel disease, irritable bowel disease? Someone that is always having gas or bloated. So it depends on which part of your tummy is affected. And the treatment that you said you did before, what type of treatment? What did you take?
So you properly treated UTI. Okay.
Treated UTI, well, my question to the person is with what? And after the treatment, did you do the test again to be sure you are treated? Or you only felt your symptoms are subsided? You only felt better a bit before the thing came back? So it depends. I don't know. The person needs to be tested again to be sure it's UTI. And if it's not UTI, the person can go for swab if she is having discharge. Go for endocervical swab or eye vaginal swab to check if it's an infection. So if it's a vaginal infection, then she should be treated for that. And if not, she can have an ultrasound scan done, because it can be fibroid that is causing this pain. If she has fibroid coexisting with pregnancy, it can continue to cause severe abdominal pain. So,
okay, thank you very much, doctor. The question I want to know,
okay, I'm treated again.
how can I manage pregnancy with degenerated fibroid without complication?
Degenerated fibroid without complication. Once the fibroid is there with pregnancy, it is pain. It will keep causing pain. So the management is analgesic, pain reliever. You keep taking the pain reliever till you deliver. And if there is infection, because it's degenerating, it can cause infection. You will be admitted, given an IV fluid, antibiotics, depending on the severity. So the person might need admission, IV antibiotics, IV analgesics, and check the blood level, like that.
Okay, thank you very much again. Is there any health benefit of sex during pregnancy? If yes, at what stage is it advisable or not advisable?
Okay. Well, benefits. Benefits, how should I put it? Benefits is essentially at 10. Yes, your baby is around 37 weeks. That is when I can say there's benefits. The other parts is just for your own pleasure. But the benefits for intercourse is at 10. And at this time, that is the most uncomfortable period for a woman to have intercourse because the abdomen is very big. You are just tired. So the benefit there is that the semen from the male contains what is called prostaglandin, something called prostaglandin. This prostaglandin can help with ripening of the cervix. So you are 37 weeks. You know, some people that have prolonged pregnancy, when you go to government hospital, all those matrons, all those nurses, midwives, when they give health talk, they said, allow your husband, let them help you, and blah, 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 like that. The help they are telling you is because when you have intercourse with your husband, the prostaglandin from the semen helps to ripen the cervix. So usually after intercourse, because of this prostaglandin, women have abdominal pain. So that discomfort, you know, after intercourse, you keep having this severe abdominal pain, and this is not something nice that women like. But it's good because it prepares, yes, let me put it like that, prepares the cervix for delivery. So rather than wait and abstain and have a prolonged pregnancy, your pregnancy is more than 40 weeks, you are still carrying this baby about. The nurses will tell you, allow the daddies to help you. Next question, please.
Okay, thank you very much. It's a very brief one. What is the recommended age rate for women to marry medically?
Marry, well, from 18, let me put it like that, from 18 years. So that you can have time, space your child, have the number of kids you want before 35. You can still have, as I said before, you can still have normal kids after 35. But you know, because of the chances of having babies with defects, it's better to have had completed your family before that age.
Okay, good. So Dr. Ma, please, I would like to know if my monthly period is normal or not being my first period after 2 years of breastfeeding. The period lasted 10 days. After 5 days interval, another period lasted 5 days. And after 3 days interval, another lasts 7 days. And at the moment, I am at the moment, what is the problem of course?
There was the line wasn't so clear. I think you said there was amenorrhea for 2 years. 2 years because she was breastfeeding, right?
Yes,
and now
my monthly period is normal, or it said not being my first period, like not having my first period after 2 years of breastfeeding. Okay. The period lasted 10 days. After 5 days, after 5 days interval, another period lasts 5 days. Okay. And after 3 days interval, another lasts 7 days.
Okay. This is kind of irregular. It's irregular, definitely. And the reason is because she has had amenorrhea for 2 years because of the lactation breastfeeding. Some women, when they are breastfeeding, they don't menstruate. So the lining, the inner lining of the uterus is already thick over these 2 years. That's why she keeps bleeding like this. So 10 days, after which 5 days. So what are you supposed to do? By the time, the 10 days because you've not had period for so long. Then the 5 days period again. You should see your doctor, get prescription for something that will stop this bleeding, and take iron tablets so that you don't have anemia. So it is not regular, it is not good, but there's a reason why it's so. I hope it makes sense.
Okay, thank you very much. The questioner wants to know what can a woman who found out that she had untreated PID after several years have passed do?
No, I didn't get that.
What can she do? What can a woman who found out that she had untreated PID After
Okay.
9 years have passed, what can she do to prevent ectopic pregnancy?
Oh, okay. Well, if she is not currently having any symptoms or any discharge, the only thing she can do if she's having any symptoms now is just go for tests. Go for tests, and if there's still any infection there, get treated. If there's no infection going on at present, there's nothing she can do to prevent ectopic pregnancy. Only to say make dua. It's only dua she can do. Medically, there's nothing to.
Okay, I may Allah accept it.
Apart from
Is it
treating
possible to,
the PID.
okay, is it possible to overdose on folic acid? Just read the question that's written.
Well, I don't know if I should say it's possible. Well, someone can overdose. Usually the dose for folic acid that should be taken in pregnancy is 1 milligram. Some can take as low. You can take in 400 microgram is still okay. But for people that have diabetes, that's why I said they should start folic acid before even getting pregnant, if possible. But even if they did not start, once they know they are pregnant, they should start folic acid. Their own folic acid is 5 milligram, not the usual folic acid everybody is taking. They should take a higher dose because of their chances of having these babies with defects. So I think that is that. You should not take, except if you deliberately want to commit suicide, shouldn't take overdose. But if you still take up to 5 milligram, there's still no problem.
Okay, someone wants to know is it normal for sperm to be released from the vagina after sex?
Yes. What people see in Yoruba, I know they call it Eda. That is just Yoruba. Usually, what they see that comes out is the semen. From their picture, where is it again? Sorry, 1 minute. On the screen.
Okay.
What happens once the semen is released into the vagina? It goes up. It goes inside these sperm cells. Okay, our brother is supposed to show us one video, but unfortunately, we were unable to watch the video. So the sperm cell, what is released into the female is the semen. The semen contains fluid, other substances, and the sperm cell, the spermatozoa. This is the spermatozoa, very tiny, tiny things. The spermatozoa has left. This is where the semen is being released. The spermatozoa, the tiny, my professor calls it, they call them little rascals. They swim in. Everybody, they are in a rush. Millions, they swim in. You can see them very tiny here. They swim in, the first person to get to the egg, to fertilize the egg. So the remaining thing that comes out, the thing cannot keep accumulating inside the female now. So the remaining thing that comes out is just the fluid, the semen. The spermatozoa themselves, they are very tiny, microscopic. They are here, rushing to fertilize the egg. So what comes out that people see and those people call Eda is just the fluid, just the semen, the water and the other substances. So that's what
okay, thank you very much.
Okay.
Thank you very much. So another question, how does a breastfeeding woman who has not resumed menstruation yet know her ovulation period?
It's difficult to know. So once you are not menstruating yet, except if usually if they are not menstruating, they should not be ovulating. But anything can happen. Sometimes our body just does whatever it likes. So if you are not menstruating, you should not ovulate. But sometimes it might just be that month that ovulation occurs, and she just became pregnant. But it's not usually possible to know if you are pregnant, except you do tests. You have some tests that can be done.
Okay, thank you very much. The questioner wants to know, in a situation of a 9-week, 1-day-old pregnant with 4.0 by 5.0 centimeter uterine anterior intramural fibroid and 2.8 by 2.7
Centimeter,
Yes.
right? Okay.
Centimeter, cm.
Okay.
And 2 point, should I take it again?
No, I got 4.9 cm intramural.
Yes, 4.9 by 5.0 cm uterine anterior intramural fibroid.
Okay.
And a 2.8 by 2.7 centimeter fundal intramural fibroid. What do you advise? That's at a 9-week, 1-day-old pregnant.
Okay. Well, I can't, there's nothing to advise other than to be patient and be careful. This fibroid is big, 4.9 cm. We can assume as we try to, what should I say it? Try to, I don't know the English now. So 4.9 is just like 5 by 5 cm. 4.0, okay. 4.0 by 5 cm intramura, that is in the muzzle, in the anterior, and almost 3 by 3 cm in the fundal part. So this fibroid is still going to get bigger. It's big and it's still going to get bigger. So the problem that can occur with this is one, pain. It can affect the growth of the baby because it will get bigger. As the baby is getting bigger, it's also getting bigger. And it's to be taking the supply from the baby. So such a woman, there's nothing to be done. She's already pregnant. We cannot bring out the baby. And we cannot do anything to the fibroid now. We cannot operate on the fibroid. So just wait. Watch waiting. Rest as much as possible. Take an analgesic. And if you are buoyant enough, get a tablet called Duphaston. It helps to relax the uterus so that it will not, this fibroid will not keep encroaching on the baby to cause abortion or to hinder the growth of the baby. And the woman should eat well also, so that there can be enough for both the fibroid and the baby to grow.
Thank you very much.
Iron. Okay.
Okay.
Okay, I said and take iron tablets to boost the blood. Okay.
Okay. Thank you very much, doctor. This will be our last question.
Yes,
another question will be sent to you, inshallah. So the last question is, can implant contraceptive cause irregular menstrual period? Thank you.
Yes, it can. One of the side effects of implant-on, is spotting. Not just implant-on, usually all those hormone contraceptive, whether it's injection, depot injection, or tablets, or the implant-on, the most common complication is spotting. The woman keeps spotting. So, that is it. That's the question, right? Can it cause?
Yes, can it cause irregular menstrual period?
Yes, it can cause irregular menstrual period. The woman keeps spotting. Although, usually after maybe 6 months or to 1 year, it can now stabilize. The body is now used to it. Then the bleeding can stop totally. But at the initial stage, it can be frustrating because the woman keeps having irregular cycle. Anytime the blood just comes, just sees blood every time, and not pray solar. So that's the usual side effects. But after some time, the body gets used to it, and the menses stops coming.
Okay. Thank you very much, Doctor. That was an excellent and very insightful presentation from you. We are extremely grateful for this opportunity. May Allah subhanahu wa ta'ala increase in knowledge and understanding. And we hope to have you some other time again, and we believe that you answer us. Thank you very much. Thank you very much for this, inshallah. So we have all got the message. What we are trying to do, our aim is to educate everyone, to bring to everyone important information about our health. That's how we started with pregnancy. I believe it will help us to take some actions to address some of the, at least what we can do, what we are capable of doing to reduce or at least prevent some of the complications and ill things that we are hearing. So may Allah subhanahu wa ta'ala make this easy for us and grant all pregnant women peace and successful. Thank you once again. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum salam wa rahmatullahi wa barakatuh.
And to our audience, thank you very much for joining. We are very grateful. Thank you so much for joining. May Allah subhanahu wa ta'ala reward you abundantly and grant you sound health in this critical time.